Hello doctors, welcome back to Jab Studies Made Fun for Medicine Part 12. In this part, we are going to talk about MI, myocardial infarction, Nstemi, and much more about the drugs. So without further ado, let's start today's session. So whenever we talk about MI, let us talk about the first sign you notice in a patient having heart attack. First you will see is he'll clench his fist and keep it in the center of the chest because of the pain. This is known as Levine sign. Okay. After this, now whenever you have a myocardial or any patient with respect to chest pain to the emergency ward, mostly it is because of acidity, which can be treated by Pentop. But just because of the most common scenario, you cannot rule out MI. You have to do an ECG, then only you will rule out MI. Okay, with respect to whenever you have a chest pain patient in your emergency ward, first you have to do an ECG. What are the changes you see in the ECG? Now normally what you will see is you will have the P wave. Then you will have the negative Q, R, then T, and the S, and then the T wave, right? So you remember the P wave is because of atrial depolarization, QRS is ventricular depolarization, and the T wave is ventricular repolarization. Okay. Now, what are the signs of myocardial infarction in the ECG? First of all, you need to know why these signs are there. Why is there a tall T wave? Why is there T wave inversion, ST elevation, and all? These are because it depicts the cellular damage. First, if you see, the cell gets ischemia. Ischemia means lack of oxygen. Then there will be injury. After that, there will be death of the cell. So what are the ischemic findings you find in case of MI? First of all, and the first sign you see is hyperacute T wave. Over here you can see hyperacute T wave will be there, right? The second thing is T wave inversion. Now you can see there is hyperacute T wave over here. Few might also know that in case of hyperkalemia also you have T waves which are tall. But remember, these are tall tented T waves. You can see they're quite narrow and they're tall. Okay, so make sure you know the difference between hyperkalemic tall tented T waves and tall T wave with respect to MI. Then, what are the findings of injury of the cell? That is going to be ST elevation. In ST elevation, you can see the direction is convex. Now remember, in case of pericarditis also you're having ST elevation, but there you're going to have concave. Make sure you know the difference again. So that is why I tell you whenever you study also, this is a smart study. If you have something which is left side, what is going to be in the right side? Like that, rule out and make sure you have sticky notes. Anyway, this which we are talking about ST elevation, this is known as the Pratt sign, or it is also known as the tombstone pattern. So these are the two patterns which you should know. After that, you're going to talk about death. With respect to the death of the cell, the demonstration is going to be by deep Q waves. Now understand this, that these deep Q waves, they are not going to resolve. Tall tented T waves, tall T waves, ST elevation, these are going to come back to normal after the patient's MI is treated. But deep Q waves are irreversible changes. They will be persistent throughout the life. If you see a patient and you see in the ECG, who never came to you, you will see that there are deep Q waves, which means it was an old MI or a previous MI. I hope you understood, okay? So for myocardial infarction, the three things which you see, tall T waves, followed by T wave inversion, then ST elevation, and if there is cellular death, you will have deep Q waves which are irreversible. They will be persistent throughout the life. Okay. Now, if you have a PYQ or a question with respect to your MI, current of injury is demonstrated by what? It is demonstrated by ST elevation. It is demonstrated by ST elevation. Okay. Next, let us talk about the ECG findings with respect to what area of the heart is involved. If you talk about inferior wall MI, you have to see the ST elevation, T wave inversions in lead number 2, 3 and AVF. Okay, lead number 2, 3 and AVF. With respect to anterior wall MI, you are going to see the changes in V1 to V4. And if there is severe form where there is extensive anterior wall MI, that is involvement of V1 to V6. Okay, the artery which is involved in case of anterior wall MI is your left anterior descending artery. While with respect to your inferior wall MI, it is right coronary artery. Okay, if you see over here, you can see in the lid number 2, 3 and AVF, you're having over here, your first of all, T wave, tall T waves are already done. You'll have over here the T wave inversion, and along with that, you're having ST elevation. Over here also, you can see ST elevation and T wave inversion over here. If this was a case of MI with respect to anterior wall MI, where left anterior descending artery is the one which is blocked, over here you can see from V1 to V4, you're having the same findings, ST elevations and T wave inversions. Okay. And always, we have already discussed ECG in detail in the previous medicine videos. If you haven't watched that, do check it out. It will clear most of your ECG doubts. Okay. Now, second lead, which we already talked, is the rhythm strip, where you check the heart rate and stuff like that. If you see this actual image, over here you can see, first of all, you will always see there, or over here also there will be a rhythm strip. This is lid 2, check always the heart rate and all. What you will find over here is that in lid 2, 3 and AVF, you can see over here, there is ST elevation. Okay, so this is which condition? This is your inferior wall MI. What will be the artery involved? Right coronary artery. With respect to this image over here, you can see there is no elevation over here in case of lid 2, 3 AVF. But here if you notice in V1, V2, V3 and V4, you're having involvement of the ST elevation. So this one give you confirmation of you will have this anterior wall MI involving V1 to V4. Clear? Next. If you like, we'll just summarize everything. Anterior wall MI, the artery involved is left anterior descending artery. Inferior wall MI, the artery involved is right coronary artery. Lid's involvement in anterior wall is V1 to V4. While it's in inferior wall MI, lid 2, 3 and AVF. Remember, all of these are very important because they are going to ask, these are all PYQs, okay? Now see what is the issue with respect to inferior wall MI. Inferior wall MI, you need to know that it causes an irritation to the diaphragm. That is why in inferior wall MI patients, you will find findings of hiccups as well. Now, inferior wall MI, mostly that inferior wall is around the right ventricle. And you know, with respect to anatomy, that the right ventricle is innervated by the vagus nerve. Because of the innervation of the vagus nerve, and whenever there is damage because of inferior wall MI, the patients with inferior wall MI, along with hiccups, is going to come with vomiting. Okay. Along with vomiting, the patient will also have, now because of the vagus nerve, they will have bradycardia. Very important. They'll have bradycardia. Other all types of MI, you will always have the patient has the heart rate is raising, tachycardia. The only condition in which you will have bradycardia is inferior wall MI. Why? Because of the innervation of the vagus nerve. So whenever you have a classic history, okay, patient comes with Levine sign. Along with this, these symptoms are patient is also having frequent episodes of hiccups. Patient is vomiting, and when you check the heart rate, patient is bradycardia. Confirmed answer is inferior wall MI, because there is no other MI where you will have bradycardia. Okay. What are the blood tests you are going to do in case of MI? The first and the most important one which is going to be there is you will do a tropi test after the ECG, of course. In the tropi test, normally in you and me, the blood, the normal tropi value is less than 0.04 nanogram per deciliter. But classically in case of MI, what you will see is this value is going to get double, which is known as doubling, or it is considered as the 99th centile of the upper reference limit. Okay. Remember, the tropi value is going to get raised within 3 to 4 hours. It is going to peak at 24 hours. And it will last from 7 to 10 days. Everything is written later, I'll tell you. But the first thing which you have to remember is tropi, the most important investigation. How you see the normal is less than 0.04 nanogram per deciliter. The value is going to double, hence known as doubling, or the 99th percentile of its upper limit. Okay, it rises by 3 to 4 hours. If you notice one thing, it is slowly rising. That is why you will not just do one blood. You will do serial wise. So that is why the investigation, if they'll say tropi versus serial tropi, you will have to mark serial tropi test for myocardial infarction. So whenever you have a patient who presents with Levine sign, if you see positive results with respect to ECG or positive results with respect to tropi, you have confirmed the case as myocardial infarction. You have confirmed the case as myocardial infarction. After the next tropi as a blood test, the next test we will talk about is your CPK-MB. Now CPK-MB full form is creatine phosphokinase myocardial band. This is no longer done. If I give the comparison of TROP-T, TROP-I and CPK-MB, you will notice that TROP-I as compared to other all is going to early rise. Even here TROP-T has 3 to 4, but comparatively much more early will be TROP-I. The peak of all of the three are the same. If you notice one thing, TROP-I will be lasting for 7 to 10 days. TROP-T will be lasting for 10 to 14 days. But CPK-MD, they are going to have an early fall. Within 2 to 3 days, it is going to close. So why I kept this table is you need to know amongst these three, a question comes, which one is early rising? That is going to be TROP-I. Which one is early fall? That is going to be CPK-MB. This is also PYQ. Okay. If they will ask you overall, which is the first one to rise? Many of you might answer myoglobin, but no. The answer is Heart fatty acid binding protein. Heart fatty acid binding protein rises within 1 hour. It rises within 1 hour. Remember that. It rises much more earlier than myoglobin. The last one to rise with respect to the blood chemistry is LDH levels. If a patient has reinfarction, what is going to rise? The answer is going to be your trop I. Trop I. Okay? If you get a question, which is the best investigation, which is the investigation of choice, or what is the investigation for reinfarction in case of MI, what test you will do? You will do the trop, very good, I test. So you understand how important trop I is. If we will summarize trop I, normal values are very good, less than 0.04 nanogram. In MI doubles, 99 percentile of its upper limit. It begins to rise 3 to 4 hours. The peak is 24 hours. It lasts for 7 to 10 days. It is the best investigation of choice, and reinfarction ke liye the best is going to be trop I. Now, what is STMI? STMI full form is ST elevated MI. What do you see in this? Mostly you'll see in anterior wall V1 to V4 also. ST is going to be elevated by up to 3 mm with respect to the ECG changes, and along with that you will have T wave inversion. The important thing over here is they're going to ask you what is the treatment. Now, treatment I'll give you mnemonic later on, but let us talk about the actual thing what happens in the hospital. First thing is you're going to give a dual antiplatelet therapy. Okay, in this what are you going to give is you're going to give aspirin. Even I'll advise you, if you see in your like surrounding also, if ever this happens, this is the management generally which we give. The emergency dose. In the emergency dose, you are going to give 4 tablets of aspirin, 4 tablets of clopidogrel, and 4 tablets of atorvastatin as well. Okay, but here in general, remember for your exam wise, you will give a chewable aspirin which they have to crush, 325 milligram, which is equal to 4 tablets which you normally get in the government. For another thing you have to remember with respect to pharmacology, what is the mode of action of aspirin? The mode of action of aspirin is thromboxane A2 inhibitor. Okay. For dual antiplatelet therapy, one is aspirin. The next one is ticagrelor. You can give clopidogrel as well, but remember ticagrelor also can be given 180 milligram, and the mode of action of ticagrelor is P2Y12 inhibitor. This is a PYQ I have asked in all FMGE, INI as well as your NEET PG. Okay, so where can you give this dual antiplatelet therapy? You can give it in case of Stemi, you can give it in case of Nstemi, non-ST elevated MI. You can also give it in PCI. PCI stands for percutaneous intervention will be there. Okay, percutaneous coronary intervention. So after giving a dual antiplatelet, you will check the oxygen by the pulse ox. If the patient's oxygen is less than 93, you will give them the Hudson mask, the normal mask, or the nasal mask will be there. Okay. The third one which is going to be there is you're going to give the sublingual nitrate. Now either you'll give the sublingual nitrate to put it below the tongue, or you will put the buccal spray. The dose of the buccal spray is going to be 0.4 milligram. You're going to repeat this dose every 5 minutes, maximum 3 times. Okay. Now remember the problem with nitrates. Nitrate is a vasodilator. So that is why it is contraindicated in conditions when the systolic blood pressure is less than 90 milligram mercury. It will further fall it down. The side effect of nitrates is whenever you give it, the patient will complain of very good headache. Okay, another PYQ. After this, you can also give morphine. Now, what is the role of morphine is? Morphine decreases the chances of pulmonary edema. Pulmonary edema is quite common with respect to anterior wall MI. And also with this, it decreases the heart rate, because of which you will have decreased chance of the size of the infarct. Now the side effect of morphine is it is vagotonic. It stimulates the vagus nerve. That is why again the patient will complain of vomiting. A will be your ACE inhibitors can be given. Statins can be given. Why are we giving this? We are giving statins so that we stabilize the plaque and furthermore degradation cannot take place. Okay. You will also give metoprolol. Metoprolol over here is going to be given IV. 2 reasons why. Metoprolol first of all decreases the heart rate so that the O2 consumption in the body reduces. Along with that, it reduces the infarct size. Now remember one thing, doctors. Metoprolol is contraindicated in inferior wall MI. Why? Because already the inferior wall MI, you have a classic feature of bradycardia. And if further you give a beta blocker like metoprolol, further it will be falling down on the heart rate and the person can die just because of bradycardia. So instead of giving metoprolol in case of inferior wall MI, we are going to give very good atropine, because atropine is generally given also in case of sinus bradycardia as well. You will also give anticoagulants like heparin, which is specifically enoxaparin. If you're using enoxaparin, which is a low molecular weight heparin, that can be given once a day. If you're using unfractionated heparin, that will be given 3 times a day. These are the procedures which you need to know. Now, what I can remember this with the help of is Sonam. Okay, S is for Stemi. Okay, and S is for Sonam. So S over here stands for streptokinase. I'll talk about that later. O over here is for oxygen. N is for the nitroglycerin. A, you have to remember 2 A's. One is going to be aspirin and the other one is going to be ACE inhibitors. And the statins can come here. Here S can be also remembered as streptokinase and statins. And over here M can be remembered as morphine and metoprolol in case of your anterior wall MI. So don't, if you are not able to understand all this table, just remember Sonam, you can get it. This I'm telling you in order in generally how it happens with respect to the hospital management as well. So it is good for revision and it is good for practical skill as well. So remember, mnemonic for Stemi is Sonam. Easy. Next. So what I was talking about is after enoxaparin and everything is done, now you will take the patient to the cath lab. In the cath lab, you're going to do a coronary angiography. Coronary angiography, you will find out that in the left anterior descending artery, there is no diflow, which means there is a blockage. So what you will do? You will do balloon angioplasty. This balloon angioplasty is known as primary percutaneous coronary intervention, PPCI. It is known as primary percutaneous coronary intervention. And the moment the patient comes to the hospital, and from that time to the putting the balloon, which means door to balloon time should be less than 90 minutes, which means the time the patient came to the hospital till the start of this procedure should be within 90 minutes. Okay. Now, most of the hospitals, like, they don't have this method, the PPCI. For those conditions, we will do thrombolysis or fibrinolysis. The drugs which we use over here are alteplase, most commonly done, relteplase, tenelteplase, and streptokinase. Nowadays, they don't use streptokinase. The reason why you don't use streptokinase is that you will have anaphylactic reactions. The common side effect of all these thrombolytic agents are it causes hemorrhage. Now, door to balloon time for the PPCI was 90 minutes, but door to needle time is less than 30 minutes. So the doctors should know that, okay, we don't have PPCI, we have to directly start our thrombolysis treatment and it should be done within 30 minutes. Okay. Now let's talk about microbiology. If they ask you from how the streptokinase is extracted, it is extracted by group C streptococci, specifically Streptococcus ecchysimilicis. Okay. Make sure you know this as well. Now, this is all about you with respect to your Stemi. Okay, I hope you understood. Remember Sonam. So Sonam for Stemi is Sonam. Sonam S will be standing for streptokinase or statins. O will be oxygen. N is the nitroglycerin. A will be aspirin, or A can be also the ACE inhibitors. M is going to be, one is morphine, and metoprolol for anterior wall MI. Remember, metoprolol is contraindicated for inferior wall MI because it further causes bradycardia. What drug will you give in inferior wall MI? You will give atropine, so that increases the heart rate. Now, if you have toxicities, let's talk about general pharmacology as well. Like streptokinase toxicity, you will give EACA, that is epsilon amino caproic acid. For warfarin toxicity, you will give vitamin K. For heparin toxicity, you will give protamine sulfate. And for warfarin toxicity, which is causing intracranial bleed, you will give PCC. I want the doctors to comment below what is the full form of PCC, because they have asked this multiple times. And in that option also, they will be giving PCC and vitamin K. Many will mark vitamin K because we all are commonly knowing about vitamin K. But PCC is given in case of intracranial bleed because the amount of the clot cannot be built properly with vitamin K with like very less time, for which we have to give PCC. Please let me know what is the full form in the comments below. If you see this case, a normal ECG is given. In Stemi, which is ST elevation, the word says it itself, you can see the elevation over here. And in Nstemi, you can see there is a depression. Okay. Now, what is the treatment for Nstemi? And we'll talk about the difference between Stemi and Nstemi. Again, Nstemi, a case with V1 to V4, you will see ST depression. There it was elevation. Over here it is T wave inversion. What are you going to give? Dual antiplatelet therapy will be same. Aspirin, ticagrelor. IV nitroglycerin is going to be given this time. IV enoxaparin is going to be given this time. IV metoprolol, ACE and statin. The important thing is you need to know that no thrombolysis can be done in case of Nstemi. A very important topic to understand also, and a very important PYQ as well, that in Nstemi you cannot do thrombolysis. The PCI you can do, and the time given for the PCI is within 24 hours. I hope you understood this. There, the PCI should be done within 90 minutes. Thrombolysis in case of Stemi within 30 minutes. Here, thrombolysis in case of Nstemi is contraindicated. PCI in case of Nstemi is going to be done within 24 hours. Now understand why. In case of Stemi doctors, the clot which is built, the clot which is causing the problem is made of fibrin-rich clot, which is very thick. So for fibrin, then only if this fibrin is there, then only you will do thrombolysis. On the other hand, in Nstemi, the clot is made up of platelets. Okay? And if you give biomistakenly thrombolysis, it will cause further more severe bleeding. So remember, fibrinolysis is contraindicated in case of Nstemi, while you do fibrinolysis in case of Stemi only. To summarize, Stemi, if your patient has the cath lab facility available, you will do primary percutaneous coronary intervention. Door to balloon time will be within 90 minutes. If you don't have the cath lab, you have to do thrombolysis. Door to needle time for the thrombolysis is within 30 minutes. Most commonly done will be alteplase. To talk about alteplase, a very important drug, where do you use alteplase? Alteplase can be used in Stemi. It can be used in acute ischemic stroke. It can also be used in massive pulmonary embolism. See here, alteplase can be used in Stemi. It can be used up to within 12 hours. Okay. Acute ischemic stroke you can use it within 4.5 hours. We discussed this earlier in the medicine videos. And it will also be used in massive pulmonary embolism. Alteplase is contraindicated in hemorrhagic shock because this all thrombolytic agents, they have a side effect which is hemorrhage. So obviously in further bleeding you will not give, na? So hemorrhagic shock and Stemi, and anywhere where is bleeding diastasis, which is anywhere INR more than 1.7 or 2. Okay, so make sure you know this. We are adding pharmacology as well because these are all vital points. So to summarize everything, remember, if you have inferior wall MI, the cause, which artery is affected is the right coronary artery. In inferior wall MI, you will have bradycardia, not tachycardia. You will have bradycardia. You will have hypotension. You will have raised JVP. But on auscultation, you will see the lungs are clear. What you will not give, beta blocker like metoprolol. What you will give atropine because it will help to increase. Remember, atropine is generally the drug of choice for sinus bradycardia. In anterior wall MI, you will have left anterior descending artery damage, V1 to V4. The symptoms and the signs you will see is tachycardia, hypertension or hypotension based on whether it is completely clotted, the blood only will not flow. And along with this, because the clotting will be there, you will have pulmonary edema. Now, because pulmonary edema is found in anterior wall MI, in IVF, intravenous fluids are contraindicated in case of anterior wall MI because it will further exacerbate the pulmonary edema and you will have dyspnea and all. I hope you understood this much. This is all what you guys need to know with respect to myocardial infarction, with respect to the questions, and you will be able to solve most of them. I hope you understood. If you have any other doubts, please DM me and see you in the other side.